you hear me well?
Very clear.
Okay. And again, thank you so much for the invitation to the organizers and the organizing committee. It's a great pleasure to be again with you after 1 year from our last interaction. It's a great honor to participate again in your conference. We will talk today about the heart failure epidemic and myocardial recovery and new directions. And I'd like to start with this slide, which depicts how myocardial recovery and reverse remodeling is something that we see in our everyday clinical setting while we round on patients in the wards. You can see here in the inner ring how we can reverse remodel and recover the heart when we treat it with biventricular pacing with CRT here, when we replace the aortic valve with surgery or TAVI, when we control the heart rate here with the tachy-induced cardiomyopathy, when we abstain from alcohol, when we give beta blockers, when we give ACE inhibitors or Entrestor. And so the message of this slide is that myocardial recovery is not something exotic. It's something we see on our everyday clinical life, and it's challenging the dogma that prevailed for a long time that the failing human heart cannot improve after severe injury. So the question that arises is which of those paradigms could be used as investigational model for further clinical and mechanistic insights. And today we'll talk about one of the things that is mentioned there, the LVAD, which stands for left ventricular assist device, which can induce myocardial reverse remodeling in some patients, and maybe we can use this to learn more, and we'll explain how. And for the people that they're not familiar with what this is about, I'm just sharing with you this cartoon here, which shows how the left ventricular assist device works. Sucks the blood from the apex of the left ventricle to the pump. This is the first generation, the bulky big pumps. Now we have much smaller. And then from there, it pushes the blood, the pump to the aorta, and from there to the circulation. So nowadays we use left ventricular assist devices as bridge to heart transplantation. We use them as destination lifetime therapy. But today we will talk about this investigational indication, which is bridge to heart recovery. And so I have the honor and the privilege to chair the NIH working group on myocardial recovery, and this is a white paper for with our recommendations that were published in 4 major journals representing the College of Cardiology, the Surgical Society, the Heart Failure Society of America, and the Artificial Organ Society. And so what we kind of describe there is that, as we know, load is central in this process called cardiac remodeling, in this vicious cycle. And so by reversing a significant part of this load with a left ventricular assist device, we may be able to induce myocardial recovery. And so why this model is so provides so much insight is that we get through these models something that it's unprecedented in cardiovascular disease. We get the human heart tissue. When the cannula goes in, we get this piece of tissue, as you can see here, which allow us to do studies at the histological and ultrastructural and molecular level. And then we kind of follow these people over time with echoes and hemodynamics, and we know who, what is the percentage of the people and who will improve his or her heart function and who won't, and in between the spectrum. And then at transplantation, we can take the whole heart and then we can see what changed. And by looking at it, we may be able to gain insights on what drives this myocardial recovery. So the LVAD population is a unique recovery model because, again, of this access to human heart tissue and blood, something that the oncologists always had. And that's why they're so far ahead of us in personalized medicine. We never had this opportunity. That's why this is a great opportunity for cardiovascular medicine to gain real insights on what on the mechanism of the disease. And of course, we can assign it, as we said before, to phenotypes, so we can gain insights. And so in this white paper, we redraw again this rainbow, and then you can see there all of the things that they can recover a heart. And MCS stands for mechanical circulatory support, or LVAD. And what we show there is that it can serve as a magnifying glass that you can use in order, by taking advantage of this human tissue and this setting, to gain insights at a deeper level. And we'll share with you some examples. So this is a patient, one of our patients, and you can appreciate in the 4-chamber view how the heart began beating better a few months later. And this is another patient. We call this patient B. It's a non-responder. Despite similar heart failure etiology and duration of heart failure and duration of unloading, the heart didn't really improve. So why this happened, right? And so how did I get involved with all this? We are talking in a country with not as much resources as the United States. And I'd like to share with you a story of how I took advantage of my training in the US in a similar country without a lot of resources, and how I started. And there are younger trainees, and I interacted with them last year. So how did I get involved with all these, and how we can apply some of these in countries like Indonesia? So I got involved with all these things when I was a medical student, and this is my mentor, John Nanas, who's an international leader in experimental and clinical heart failure. And while I was a medical student, I ended up, because this center there is historic in mechanical support. This is where the balloon pump was developed in collaboration with Utah. And I found myself doing a PhD thesis in PICS, in pulsatile versus non-pulsatile support. As you can see here, the whole team, my colleagues, that they are now practicing cardiologists and surgeons, when we were doing these experiments in pulsatile versus non-pulsatile flow. And so in 2001, when the field was ready to go from animals to humans, my mentor sent me in Utah, where he used to be and his mentor used to be. And that's how transplants started in Greece, with the collaboration with the University of Utah. They sent me to do these things that I was doing in animals, now in humans, at the University of Utah. So I came here in 2001. The plan was to stay for 2 years, learn about VATS, and then go back, start a program at the University of Athens. And this is the REMARCH trial that was published right when I went there and put LVADs on the map. This is the directors of the program. Utah was the top enrolling site and the site with the best outcomes. I spent 2 wonderful years. I learned a lot. And then, as the plan was, 2 years later, I went back to a country with less resources than the United States to apply all these things that I learned there. And we started the first LVAD program. That's how I got interested into recovery, because about the same time, Sir Magdi Yacoub, who is a living legend of cardiovascular disease, began collaborating with our program, and we started the so-called Hairfield Athens Recovery Program. And this is when the life makes it, the turns and lag impacts your life. Having the opportunity to work with a living legend was a life-changing experience. And all of the younger trainees that are listening, and I met with them last year, they should look for mentors and get inspired from them and learn from them. So we did simple things. The first thing we did was look at the LV and diastolic diameter and how it shrinks as the LVAD unloads the heart. And then we looked at other simple things like changes in the EKG, electrophysiological reverse remodeling. And you can see here how the QT and the QRS shrank while the VAD was unloading the heart. And here we did a little bit more fancy things, and you can see how the sympathetic innervation changed and how it improved after the LVAD unloading, again, as part of this program. The question, though, was whether on top of these different aspects of cardiac remodeling, you can recover the heart as an organ and remove the LVAD. This is the first case we explanted. And this is one of the patients I used to know from the time I was a fellow, before becoming junior faculty there. And I knew that he was as chronic as it can get. You can see the LVDD there, 92. The EF, 15%. You can appreciate the X-ray. 14 weeks later, you can see the cannula here of the LVAD at the apex, and you can see how the heart shrank, right? You can see here how we turned down the pump to the minimum. I was doing hand pump with Sir Magdi Yacoub, so the blood in the pump is not going to, clot. And the patient met all of the criteria, recovered his heart, and he had excellent exercise capacity with the heart 10 at the minimum. And we removed the pump. and then we win the LVAD. And then 7 years later, you can see here the sustainable effect. I can open a parenthesis here. The younger trainees can take out their smartphone. They can take a picture of Sir Yacoob and the way he looks at this patient. Just take a picture of that, save it, and this is how you should practice your medicine. Just take a look at how Sir Yacoob is looking at this patient. Close parenthesis. So the question now, is this a fascinating and rare anecdote, or a consistent and real phenomenon that we can learn from and advance the field? That's the question. With that question in mind, 6 years later, after we established the program at the University of Athens, I was recruited back in Utah. And I knew the strengths of the program from my training there. And I knew that we can build a recovery program which can have a clinical component and a science component to begin understanding this phenomenon. So fast forward from 2008, a month ago, to this clinical trial we just published in Circulation. And in the meantime, we did other things as well that I'll show you a little bit during this presentation. But I go directly to this multi-center trial that illustrated how myocardial recovery can be reproducible in many centers. We included patients that they have non-ischemic cardiomyopathy, selected population with less than 60 years or age, low EF, but big hearts, and the heart rate duration not as prolonged. And these were results we got from other studies in the past showing that this is the population that can respond the most. And this is the enrollment. We let the enrollment with Louisville and Penn, University of Pennsylvania. And these are the explantation criteria. You can appreciate there that we turned down the pump at the minimum. And then if the echo and the right heart cath was within normal range, then we went ahead and removed within the pumps. This is just from the baseline characteristics. And again, this is published in Circulation a month ago, so you can read about it more. But with red here, I just want to say that these hearts were dilated chronically. So we're not talking about myocarditis, acute patients that they will spontaneously recover anyway. So the echo core lab was in New York, in Montefiore. You can see how the EF improved over time. And here is the overall results. You can see how almost 50% of the patients met the criteria, and we weaned the pumps, and we left the patients, we aborted transplant, and we left the patients with their native heart. I'll show you later the long-term durability of this response. But the question that comes up is, okay, that was selected population. These are the inclusion criteria that you can see there, right? And so these patients were with the criteria we said before. How about all comers? How about patients that they both ischemics and non-ischemics, all of the advanced end-stage patients? What happens in this case? So this is Dr. Catino and Dr. Weaver-Pinzon. Dr. Catino and Dr. Weaver-Pinzon, when they were fellows working with me, they read thousands of echoes, serial echoes in these patients. Now Dr. Catino directs our cardio-oncology program in our echo lab, and Dr. Weaver-Pinzon is faculty at Ochsner in New Orleans. And so we put in this study the bar, we followed these people, 154 people, all comers over time, and we put the bar, I think, high. Whenever these patients improve their EF more than 40% and their volumes decrease more than 20%, we call them responders. And as you can see here, we saw that 5% of the ischemic cardiomyopathy patients and 20%, 1 in 5 of the non-ischemics, with an average 14% of all comers, improve over 6 months, which shows to you what is the response rate that you can expect in all comers, not in a selected population. The question becomes, is this reproducible in other centers? This is Dr. Omar Weaver-Pinzon, also was tortured by us when he was a fellow. He read also thousands of echoes, and this is a study he did using the Intermax registry. Now he's junior faculty, as we said, with us. And when he was a fellow, he did this study where he went to the National Registry of the United States. We had at that point in time 15,000 patients. Only 1% got explanted for recovery within the VATS, because most programs, still most programs don't have programs focused on recovery. They have other research interests. We looked at the other 15,000 patients that they didn't remove their VATS. We looked at their echoes, the ones that they had follow-up echoes, and 7,000 patients had follow-up echoes every 3 months. And so what we saw there was another 12% of patients improved their EF despite being so low before the LVAD implantation. They improve it during the LVAD support to more than 40%, 12% of the patients. If you add the two, you get to 13, which is similar to the percentage we saw in our program at the University of Utah. So the Columbia group got the Intermax data, the national registry data a little bit later. They did the same study and they found the same results. Again, showing that this is reproducible in other centers as well. Maybe wondering, okay, this sounds almost too good to be true. Is this durable? Are you going to win the LVAD and leave the heart, which was dead, and you think that this heart came back like Lazarus? So is this a durable result? So the patient, when you call him or her in your office and you talk about these things, the patient always asks the question, okay, you see that my heart recovered, but how durable is this going to be? Why don't you just go ahead and transplant me? Do you have data showing that this is going to be durable and I should abort my transplant? That's what the patient asks. And this is the Healthfield experience where they took 40 patients that they explanted and they compare them with exactly a matched group that they went ahead for transplant. And they found similar results. And as you know, we don't have donors for everybody. So this is a way to use these precious donor grafts in a way that you can give them to the ones that they don't recover, and you can save them, the hearts, and don't give them to the ones that they will recover, given that they will do similar. Again, of course, this is not randomized, and we're doing more studies now to investigate this even further. But this durability observed in Healthfield was also observed in the multicenter trial that was just published in Circulation with the 6 United States centers, again showing that this is reproducible. You may ask, okay, that was survival. How about exercise capacity? Can these people walk and exercise and do well? So you can see here with orange circles, the patients that they got their VAD explanted compared to healthy controls. And this is their exercise capacity and the peak oxygen consumption over the decades of age. And you can see how comparable they are. And you can also see here the durability over time, to 7 years follow-up, and the stability of exercise capacity in these people. We need to learn more. I'm mentoring Snehal Patel from Montefiore, and we are collecting from all over the world. The centers responded enthusiastically, and we have more than 400 patients now from all over the country that they're sending us their outcomes long-term after they remove the LVAD, so we can see what happens in these patients. And we also have response from Europe that they're also sending us their data, and we will soon publish this experience. So can we predict this? So we can select the patients better and we can focus on those. This is Dr. Bonyas, who trained in Hopkins and in Utah, and now he's back at the Onassis Heart Center in Greece. When he was with us, he used his experience from Hopkins that he trained in rotational mechanics. And we hypothesize here that all of these people before the LVAD have low EF, as we know. They are advanced end stage, right? So what we hypothesize here is the ones that they retain the torsion, despite low EF, the minority of those, these are the ones that they will recover. And indeed, that's what we found. So this is an echocardiographic predictor of response for the intervention. This is again Dr. Weaver Pinzon working with the Intermax registry, where he found some very reasonable things from the charts that can predict this response. So you can see here that the younger the patients, if they are non-ischemics, if they have not been sick for many years and their heart has not been very dilated, and it makes sense, right? If somebody's burned out sick for 10 years, it's not easy to bring this heart back and recovery. So these are the clinical predictors from the charts. One of the main reasons we are doing this program is not just to help the LVAD patients and the end-stage patients, it's to use them and learn from them and apply to the broader epidemic of heart failure in order to find what drives this. So we're collecting tissue from all over the state of Utah and the surrounding states, and with these collaborating sites from all over the country. We had more than 500 patients already collected. And when we looked at the changes at the gene expression level between the responders and non-responders, I'm not going to go into the details given that this is mainly a clinical audience. I'm just going to give you a couple of clues. You can see here that we get a lot of signals from a lot of pathways. So can we figure out, can we get some clue where to go and focus? This is again, Dr. Omar Weaver Pinzon looking at the responders, and we focus at the ones that they improve the REF to more than 40%, and we plot this response over time. And you can see there that most of this improvement happens quickly, within a month or two. And because of this gave us insights. It's an example of going from the bedside back to bench, and we went back to metabolism, where the changes happen quickly. And so we focus on that. And so this is the paper that we published a couple of months ago in Circulation, focused on this tissue from these patients, where we show all these accessory glucose pathways, how they are implicated in creating new therapeutic targets for heart failure. I'm not going to go into the details. The paper is published, and you can go read more about it if you are interested in cardiac metabolism. So what is our strategy to impact the field beyond this end-stage small population? We take the tissue, as we said, like the oncologists always had, and now it's unprecedented for us. We take it before, and we follow the patients, we phenotype them as we showed you before, and then at transplant, we take the whole heart. And we screen this heart for pathways that they're changing, and then we go back in the lab. I'll show you another example later, in order to see which of these changes are mechanisms versus which of these changes are just epiphenomena. And when we find the mechanism in the lab, at the lab basic level, we can bring it back to the heart failure population as novel therapeutic targets. That's the plan, that's the dream, that's what we've been working on. Do we have any success in this? Let me become more specific of this example and how we used it the last few years. We had these findings from the proteomic analysis, and we focus on the best biomarker changes, and we knock it out, or overexpress it in the mice, and we just published yesterday in the prestigious Cell Metabolism our work in mitochondrial pyruvate carrier. Again, showing how you can start from the bedside, go to the bench, identify and prove there that this is a mechanism in order to bring it back, as we will do now with this target, to humans. So again, to summarize the whole message, we love our LVAD patients, we love our transplant patients, but this is just a small percentage, up to 10% of the heart failure patients. We are using this paradigm in order, this is the bottom and the base of the iceberg, in order to uncover novel therapeutic targets to impact the whole heart failure epidemic beyond the stage. This is a big program. As you can imagine, too many things going on. And this is the collaborators from all over the country and the world that they're working with us on multiple aspects of these projects in order to uncover therapeutic target. And these are symposium we do every year. This year we'll do it virtually, so you can participate even easier from Indonesia and Singapore and submit your work and discuss with us about all these things. The last two slides are more relevant to Indonesia. You may be wondering, we don't have all these things, guys. Well, I'm going to share with you what the Chinese did. They sent people to us, we trained them for 6 months, and they went back, Dr. Wang, Tao Yang, Bing, we trained them, they went back, they had to go through a lot of bumps, and just a month ago, they implanted their first LVAD. And because they cannot afford $150,000 per patient, which is the price of the US LVADs, they use an LVAD from Japan, which is 10% the price, Everhard. This is something that happened just a month ago, and we will tweet and post it soon. The patient is ready to be discharged, and you will see the results. This is something you can do as well. As we discussed last year, we'd be happy to train people from your center and find solutions and help you guys out. In Europe, similar things. I showed you before my mentors and how I learned these things there. This is Utah in 1982. This is my mentor. And he was there with the rest of the team when the first total artificial heart went in Barney Clark, a huge milestone in the field. And since then, they've been working on LVADs, 35 years in this para-aortic counterpulsation device called PULVAD. You can see the papers over the years. This is how it works. It's a powerful balloon pump that goes with partial clamping on the ascending aorta. The patient doesn't need to go on bypass. It's very simple. They did chronic experiments now at the University of Athens. This is going to be a very cheap, very inexpensive LVAD, working with counterpulsation with excellent hemodynamic results. They did the feasibility and safety with my partners at the University of Athens. And now they are ready to start 3 studies in 5 hospitals. This is going to be cost-effective, bridge to recovery and or transplant for those that they're not going to recover, and simple operation with minimal invasive approach. The patient doesn't need to go on bypass, just aorta partial clamping. Again, solutions for countries like Indonesia, not countries like US that they have too much money to spend. I mean, they spend more than they have, but we have, but that's another story. So too many roads not taken, right? This is our patients. The patient in the middle is not Yanis Adetokounmpo. with the Greek flag on his chest. He's one of my patients, just so you guys don't get confused if you're NBA lovers. And this is our team, our funny picture every year. This is our whole team in the non-funny annual picture that we take. And this is the collaborators from all over the country and the world. I emphasize on our collaborators from Sichuan, Dr. Wan, Yu, and Yin, and we'll be happy to expand our collaboration with Indonesia and help you guys develop advanced heart failure programs there as well. With this, I'd like to thank you for your attention, and I'm sorry I took a few more minutes. I was told for every 100 miles away from Indonesia, you can take an extra minute, so that's why we did that. So,
thank you very much.